Good afternoon, everyone. This is Amanda Hall from the Communications Office here at the agency. Thank you for joining us today. This webinar is for ACHN updates. The items we will be addressing are profiler reports, risk scoring, BMI changes, along with a few others. Before we begin, I want to let you know that this webinar is being conducted by telephone. It is also available by WebEx so that you can view the presentation. The link to view the WebEx presentation is currently available on the agency's website, www.medicaid.alabama.gov. Please select the ACHN tab, then choose ACHN Providers from the drop-down menu. At this time, we have all audio lines muted. Please do not take your phones or computer off of mute. This will help to limit background noise and possible feedback. If you have questions, you may type them at any time during the presentation in the chat box, which can be found at the lower right-hand side of your screen. For those of you attending by phone only, you may email your questions to achn@medicaid.alabama.gov. A recording of this webinar will be placed on our website later today. We will now start the presentation.
Good afternoon. My name is Travis Hauser, and I'm the Associate Director of the Network and Providers Assistance Unit. And I will discuss the BMI changes and changes to the PCMH Recognition bonus payment. All right, body mass index BMI requirement changes. Prior to June 9th, 2020, a BMI was required on every claim submitted for the 15 E&M procedure codes. We did hear your concerns, and we made a change to that requirement. Effective July the 9th, 2020, a BMI will only be required once per year for claims to pay. This is the same for EPSDT procedure codes. You will only be required to submit one BMI on an annual basis for claims to pay. Certain specialists are still exempt from the BMI requirements, and you can find a list of those specialties in Chapter 40 of the Provider Billing Manual, and below is a link where you can get to Chapter 40. You can verify the BMI by accessing the Provider Electronic Solutions software, PES. It's also known as the Provider Web Portal. There's a link in the slide to that software. We're also in the process of updating the telephone response system, and that will be updated at a later date. When you access the Provider Web Portal and pull the recipient's eligibility information, there will be a section that says benefit limits. Under the benefits limit panel, you will find the BMI limit. Sorry, we had some background noise. But when you access the recipient's eligibility information, there will be a section called benefit limits. Under the benefit limits, you will find a section that says BMI visit. You will look at the part where it says paid. If the response is 1, then that means that a BMI has been reported on that recipient, and that you will not be required to submit a BMI on that recipient for the claim to pay. If there's a response of 0, then you will need a BMI appended to the claim, or the claim will deny. The benefit limit will be reset on January 1st of every year. This slide is just a visual representation of where you can find the BMI limit for the recipient. As stated previously, under the benefit limits section, if you will look in the red section highlighted, it says BMI limit visit. And for this particular recipient, you see that there is one paid BMI visit. That means you will not be required to submit a BMI for this recipient for the claim to pay. There may be instances where you see 5 paid visits. That is okay. As long as there is at least one paid BMI visit, then you will not be required to submit a BMI on the claim. Just a quick note, although the changes did go into effect on June 9th, this will not replace the current BMI waiver due to COVID-19. Right now, the BMI and referral requirements have been lifted due to the COVID-19 pandemic. That will stay into effect until the emergency period is over. Now we'll move on to the patient-centered medical home recognition bonus payment. Beginning in October fiscal year 2021, PCMH bonus payments will be made to providers who have achieved or is working towards achieving PCMH recognition from a nationally recognized entity. Below us, you can see the bonus payment timeline. We're approaching October of this year, which will begin fiscal year 2021, and we will actually base PCMH bonus payments off actual achievement or progress towards achievement. Certification and attestations must be received annually by the agency no later than August 1st. However, we have made an exception due to COVID-19 for this year. We will accept attestations and certifications up to September 1st of this year. The certifications and attestations will be good for 1 year, so that means every year by August the 1st, you will have to certify or attest to the agency that you have received PCMH recognition for the upcoming fiscal year. In addition to certification and attestation, you also must be an actively enrolled provider with Medicaid. You must have an ACHN agreement with the agency, and you must be contracted and actively participating with the ACHN to qualify for the 5% PCMH bonus payment. Providers who have achieved PCMH recognition through NCQA, which is the National Committee of Quality Assurance, will be verified by the Medicaid agency. Providers who have achieved PCMH recognition through another certified agency must submit the attestation form and proof of achievement towards PCMH recognition. And below is a link there to the attestation form that you will need to complete along with proof of achievement or progress towards achievement. After the August 1st deadline, we will list a listing of all verified and approved PCMH certification attestations to our Medicaid website. However, due to COVID, it will be after the September 1st deadline. Once that list is available online, we ask that you verify the list to ensure that your group is represented on the list to ensure that you get the proper payment in October. Once you have completed your form and all attachments, there's 3 ways you can submit the information. You can mail it to the Medicaid agency. You can also fax it, or you can email it to myself or Ms. Patricia Toaston. And if you also have any questions, you can email us as well. right. At this time, I will pass it over to our analytics division.
Hi everyone, this is Courtney Hansen. I'm with the University of Alabama and we work closely with the Analytics Division for calculating some of the bonus payments, including the cost effectiveness and MARA risk scoring methodology. So let's just start with a reminder and an overview of the timeline of how all of these things come together. If you notice, the green box for the cost effectiveness bonus is under January 21st, which is when the first calculated payment will be made. But the data source is for 12 months prior with a 3-month rollout, which means October 2019 through September 2020 is going to be the input dates of service for both the PMPM calculations of the cost effectiveness bonus as well as the risk score calculation of the cost effectiveness bonus. And just a quick review of the cost effectiveness bonus, that all participating PCP groups in the ACHN will be eligible for a performance payment if the PCP group meets or exceeds the cost effectiveness criteria. Medicaid is going to be using Milliman Advanced Risk Adjusters, which is MARA for short, to assess the costs of the risk of the ACHN population and then apply a customized algorithm to calculate a cost effectiveness score for each participating PCP group. To qualify for the cost effectiveness bonus, PCP groups must have a score less than or equal to the statewide median cost effectiveness score. And again, cost effectiveness scores incorporate overall average risk of the PCP group's attributed recipients, overall per member per month cost of the PCP group's attributed recipients, and overall PMPM cost of the statewide attributed ACHN population. So these actual PMPM costs of each PCP group is then compared to a risk-adjusted expected PMPM cost of each PCP group. So let's talk more about MARA risk scoring. Risk scores are standardized metrics used to evaluate a member's previous health experience and or predict health outcomes. And once again, Medicaid utilizes MARA for this. There are 2 types of risk scores. I'm sorry, I didn't move the slide forward, my bad. All right, so there's 2 types of risk scores that are calculated through MARA, both concurrent risk scores and prospective risk scores. Concurrent risk scores provide a singular standardized expected risk score given the past year's claim experience, and prospective risk scores predict future risk. So in the ACHN world, concurrent risk scores are used for cost effectiveness calculations, which we're talking about, and then prospective risk scores are shared with the ACHN to refer patients for care coordination. There is a prospective risk score shared for every single, shared with the ACHN for every single Medicaid recipient, but the risk scores that are shared are prospective. So it's important to note that these 2 scores are different. The risk score used in cost effectiveness describes the past, whereas the risk score that's used for care coordination and the risk score that is shared with every single Medicaid eligible that is shared with the ACHN is always predicting the future. All right, so to continue with the MARA risk scoring methodology, concurrent risk scores assess members' health risk based on the previous year's claim information, so that 12 months with the 3-month rollout, and predicts members' costs for that same period. So a concurrent risk score of 1 indicates that the individual had a claim experience that is similar to the average claim experience of the population, in this case, the ACHN population. Likewise, a risk score of 2 indicates that the individual had a claims experience that cost twice that of the average claims experience of the population. Once again, in this case, it's the ACHN population. The average concurrent risk scores have been calculated for a PCP group's attributed members and are considered to be the PCP group's risk score. And here is a nice confusing visual, and the only thing that I want you to know about this is that everything that's on top, that's above the inputs, is every single piece of information that is put into the MARA software and to then get the total risk score. I've highlighted diagnosis code, diagnosis sequence, and procedure code to make sure that you all know that those are being taken into consideration, and that's probably one of the best ways to know, to compare what your actions are to what comes of the risk score. And then to review how these risk scores are used, the cost effectiveness calculation compares a 12-month per member per month to a risk-adjusted expected PMPM. Groups are then ranked by their cost effectiveness score that is derived from the actual PMPM versus the expected PMPM. And then a bonus payment will be paid for PCP groups that are at or below the median cost effectiveness score. Cost effectiveness calculations include a PMPM calculation for the statewide attributed ACHN population, and these calculations will definitely exclude certain costs like the network entity case management costs, other bonus payments, waiver costs, drug rebates, and other things. And as a reminder, there is a webinar about this process already. All right, so this is how you see cost effectiveness in your scorecard. As you can see, there is your PMPM under PMPM and the statewide PMPM, and it's been broken out into various groups of payment, like inpatient and outpatient. And then to the right of your PMPM columns are your practice risk score, so that's the average risk score of all your attributed members for the entire practice group. The expected PMPM, which is your practice risk score times the statewide PMPM, what that cost effectiveness score is compared, and then the median threshold and whether or not you are below the median. And as a note, please remember that the PMPM is based on service type and is based on claims, not necessarily diagnosis. Especially, I pointed out mental health because it's not necessarily all the mental health care. It is mental health care under when it comes to claims. And then, true to academic form, here are a few papers that evaluate these risk models, and then also the MARA brochure to understand a little bit more about MARA risk scores. And I will pass it on.
Good afternoon. My name is Connie Sales. I am a senior analyst with Quality Analytics. In reference to the attribution report and profiler report modification, the agency sent out an alert last month in this report. The agency provides a listing of attributed recipients to providers each quarter after the attribution process via the quarterly attribution report number CLM 0700Q. This report lists new attributions, continuing attributions, and terminated attributions. The modifications have been made to this attribution process to include the termination reason code to both the PDF and CSV versions of the report. These codes indicate the reason an attribution was terminated for a provider. The termination reason code and descriptions are noted on the slide, and the table or legend is included on the PDF version of the report. Termination reason codes range from 1 to 5. Descriptions included are recipient has been attributed to a new provider, recipient no longer assigned to an ACHN network, and that's just to name a few. This addition of codes was included in the June report that you received. In addition, new columns were added to the CSV version of the report to include provider MPI, provider MCD, and provider name at the beginning of each row. Also, you will see the term reason and description information in the last column of each row for terminated recipients only. The field will be blank for recipients still enrolled. These changes are outlined in the red boxes on the slide. And then there are modifications to the provider profiler member level reports. Last name and first name of each recipient was added to the provider profiler supplemental member summary file quality measure report, number MGD M362Q, and also to the provider profiler supplemental member summary file cost effectiveness report, MGD M364Q. These reports will be available after July 15th. And this wraps up the modifications. The next slide lists links to more detailed resources. And I believe at this time we are doing questions.
Yes, thank you. We now have some time to begin answering any questions that you may have. If you have not already, please enter your question into the chat box. If you are attending by phone, you can email your questions to achn@medicaid.alabama.gov. You may hear a moment of silence while we look through the questions. Thank you.
Is there any consideration for increased mental health expenditures for communities that have more resources and therefore have increased cost?
Hey, so currently we are keeping an eye on that. So MARA software has updated their model, and so we still have not implemented that change yet because we're trying to make sure that there's not any huge changes regarding the software and how risk scores are generated. Please note that that is what we are going to look at after we implement the new software.
All right. We have a second question. There are some costs that are not in control of PCP, and I assume that the question is regarding kind of what a PCP can do to control some of the hospitalization, pharmacy costs, things like that.
So those are in the model, but that is also why we are risk adjusting. So if you take care of sicker patients, your average risk score will be higher than what the expected, will cause your PMPM to be higher. And so So if you have sicker patients, your risk score will be higher.
I would also add, this is Barry Cameron, I would also add to that answer, Courtney, that we have tried to exclude what we thought were costs that are out of the control of the group. So one of the slides that you saw excluded certain costs such as hospital access payments, such as drug rebates. That is something that the agency evaluates every quarter, and we will continue to do so until these calculations are done for payment purposes.
Which y'all answers another question we had in there about consideration for adjusting the scoring, which we risk adjust for based off of the total panel of patients and by each of the patients. If it's a more sicker recipient, then that goes into those considerations.
If I could add real quick, that's also a very important difference between concurrent risk scores and prospective risk scores. Concurrent risk scores take into account what has happened. So if there was a broken arm or a hospitalization of some sort, that's coming in versus those prospective risk scores that you may see through an ACHN. If somebody only has asthma, then it's not going to get taken into account. So that's where if you are comparing your average risk score concurrent versus prospective, that's where some of those discrepancies could be as well.
There's a question, are there any resources available to help with the NCQA certifications? If a recipient, if a provider registers with NCQA to work towards attaining the PCMH recognition, there are a lot of technical resources that NCQA provides those providers as they work through it. There are videos, you actually get a rep who works with them and tracks. There's a lot of tools and guidelines all for that, but there is no resources from the agency. So again, that is a decision if a provider chooses to go that route or not. There's a question, for groups that include subspecialists as well as primary care, the subspecialists will see patients that are not receiving primary care from group. A patient may be attributed to the subspecialty provider since they may see them more frequently than their primary care physician. So a pulmonologist may be penalized for not obtaining a hemoglobin A1C, which they don't manage. Is there any way to look at this situation?
Drew, we might need clarification on that question. The risk scores are made at the group level, and so the groups that have attributed recipients are also done at the group level. So that's what is taken into consideration when we calculate the scores and actually provide bonus payments for the attributed recipients. So that would be included if a pulmonologist is in the group.
But again, those are the type of decisions that each provider has to make on their enrollment. We just take how they enroll as a group. We don't determine who's in that group. It's up to each provider. So if a provider group, a clinic, decides to enroll primary care as well as specialists, but they are wanting the primary bump, the bonuses, they have to deal with that enrollment as is. How is the risk factor adjusted based on the age of the attributed patients to the practice?
Sorry, I'm taking a moment to think on that. So age is taken into consideration in risk scoring methodology, but it has less of a weight on concurrent risk scores than it does in prospective risk score models.
So for prospective, because as you age, you expect it to have increased utilization, so that's where it goes into effect. But concurrent, it is included, but it's more of based off of current utilization. So you could have a very healthy 65-year-old compared to a 65-year-old who's had a heart attack and some other issues. The age is not really the factor. It is more on the actual utilization of services.
Yes.
Okay. Are immunizations pulled from imprint as well as from billings? And that answer is correct, yes. We pull not only claims data, but when we do the annual reports, we also include immunization registry data. So we do encourage all providers to make sure you're entering into imprint, but anything that was entered at a clinic or anything that was also entered in imprint, we do take into consideration for quality measures.
I would also add to that, Drew, that we did identify a data issue with the transfer file from the immunization registry earlier this year. The agency is taking actions to correct that, and that should be accounted for by the time we have the full year cost effectiveness calculations for bonus distribution. Okay. Okay, and it should be corrected in this quarter's report, this upcoming quarter's report.
Since this is a new process, would AMA take time to educate the PCP so they can become eligible to get maximum benefit? That would be what these webinars are served purpose for. I'd also highly recommend all providers to go back and review the webinars that we did in August and September. Those all are out there. The slides are posted as well as the YouTube video, so you can watch it at your leisure. I would also encourage you to work with your ACHNs. That is another resource. The ACHNs are there to work with you and help work with any questions you might have. I don't see any questions in the inbox. Let's see, any more? And I don't see any more. I think we've addressed everything in the chat box. We'll give it maybe 1 or 2 more minutes to see if we get any more questions. If not, we will end the webinar. But I do want to let everyone know that we will be posting the slides for this webinar, as well as a very nice handout kind of explaining the MAR risk score methodology, as well as we'll be posting a video of this webinar all on the Medicaid website. Just go to medicaid.alabama.gov and go to ACHN providers, and then everything, all the presentations are located there. All right. As we don't have any more additional questions, I think we're ready to end the webinar. Mandy?
Yes, that's fine. Thank you for your time, and we appreciate your attendance. If you were not able to submit questions due to attendance by phone, you can always email them at achn@medicaid.alabama.gov. Thank you.